Good morning, good afternoon, good evening, ladies and gentlemen. I am Paola Barberino, the CEO of ADI, and I am here to moderate what could be one of the most interesting discussions in this conference. It is a discussion around the global figure for prevalence and incidence in Alzheimer's disease and dementia. It is my pleasure to welcome here today quite an extraordinary panel, which I hope is going to come on screen so that then I can ask the panelists to raise their hand and introduce themselves. So with me here today, there are Tarun Dua of the World Health Organization. There is Emma Wilson of IHME. Tarun is joining us from Switzerland, Emma from the west coast of the States. We have Martin Frings and Mélène Guerchet. Martin and Mélène, if you could just wave, that would be lovely. Martin at King's College and Mélène formerly of Martin's group and now with GBHI. I have Adelina Comas-Herrera from LSE in London. I have Emiliano Albanese from Switzerland. Emiliano, there you are, one of the architects of the GDO. And last but not least, I have Anders Wimo of Karolinska Institute, currently collaborating with IHME and formerly one of the major collaborators also of 1066 and Martin, the man who is providing us with a bridge between the old and the new. Now, before we start our panel, I would like to ask direction if we can please launch our poll. We would like to know what is your field of work. That will give us a sense of who is listening to this conversation today. Please, can we have the poll? Maybe the poll is not available, in which case I will then ask now Tarun to start with her presentation. We'll try and do the poll later once we understand what the issue is. Thank you so much. Tarun, please. Tarun, of course, with the Department of the WHO of Mental Health and Substance Abuse, our stronger backers and supporters in everything to do with dementia and the initiators and architect of everything to do with the Global Dementia Action Plan. Tarun, the floor is yours.
Thank you very much, Paola, and thanks for giving us the opportunity to be present and talk in this session on the global burden of dementia. Next slide, please. So when we talk about data, the question that comes in is what is WHO's role and interest in monitoring the global dementia situation, including the burden estimates? We have all seen with COVID-19 the importance of data, and I think it will be preaching to the converted if we talk about why data is important. But coming specifically to WHO mandate, the important one is the Global Action Plan on Dementia, that is from 2017 to 2025. And in fact, there is a renewed action through the new resolution coming on epilepsy and other neurological disorders, and I'll talk about it later. WHO has been monitoring and releasing data since its inception. The latest, in fact, which is quite a bit hot off the press, is the World Health Statistics report, which was released with the global health estimates yesterday. And the important figure for us, for this community, is that it showed again that dementia is among the 10 leading cause of deaths. The third point that I wanted to make today is that when we think about these estimates, it's not only prevalence, incidence, deaths that are important, but also the cause. And so we have the panel with Anders, who's going to talk about the direct, indirect costs associated with dementia. And the last message from this slide is that WHO will be releasing its global status report as an accountability mechanism to the Global Action Plan, taking stock of where we are towards the implementation of its targets, what are the accelerators that are required by everybody, by WHO, by member states, by civil society. And we will have the new dementia burden estimates including in that. Next slide, please. So when we talk about data, the importance of data is that how do we generate that data and how do we use that data? And I just wanted to briefly mention SCORE from WHO. We all know about scorecards, but I think what it does is this package from WHO tells us that how can we have timely and reliable data to drive strategic health action. So S stands for carrying out surveys related to different population and health risks, counting births, deaths, and causes of death, and also looking at the disaggregated data to see what are the inequities, what are the disparities. Balancing it with the health service data in terms of utilization, in terms of the facilities that are available, so including the health facility assessments. R standing for analyzing and reviewing the data, and E, enabling, meaning by the data is used for policy and action. And I think that's an important point. When we talk about this data, it is about that how do we use the information on the numbers for better policy and planning. Next slide, please. Now, when we look at the dementia prevalence, incidence, or death data, Emma will be talking about the numbers from Global Burden of Disease, and rightly, it looks at single cause of death and mutually exclusive disease classifications for the purpose of monitoring dementia prevalence. But when we are thinking about the policy response, all causes of dementia are important, because when we are thinking about services, it's not about people who have Alzheimer's disease, but also who have, for example, HIV-associated dementia or Parkinson's disease-associated dementia. So we are going to bring all of this data together, the all-cause dementia, and include it in the global status report that will be released next year. We are all very well aware of the need to monitor trends over time to see what's happening. So what kind of adjustments that we need to make. In analyzing the time trends, one also needs to be careful, because what is also happening is that there is strengthening of the health information systems that is happening. So sometimes when we see an increase in dementia deaths, it may be explained by change in coding practices. So all those methodological issues need to keep in mind. And as I mentioned, that it is not only the epi data that is important, but also on policies and services. And all of this is part of the Global Dementia Observatory. We have data from first 60 countries, and these will be included in the forthcoming Global Status Report on Dementia. Next slide, please. I'm sure a lot has been discussed about COVID-19, and I'm not going to take a lot of time discussing that. The only point that I want to make it is that we need data to measure or quantify what are the service disruptions. We need to determine and monitor the risk of people with dementia, and we need to monitor and measure short and long-term impact of the pandemic on not only on patients, but also caregivers. And this has to be in terms of health, social, and economic impacts. So there's quite a bit of data measurement and processes and standardization that will be required in the coming years. Next slide, please.
Tarun, I need to tell you that you're over time.
So I'm going to finish now just to say that the WHO's mandate of working on the brain health and optimizing brain health is extremely important, and we'll be working this year, next slide please, on an intersectoral action plan on epilepsy and other neurological disorders. So thanks, Paula. I'll stop here.
Thank you very much for explaining to us the genesis and where is WHO going with the figures. This is a very important setting of the scene. Can I now please give the floor to Emma Wilson, who will tell us about IHME involvement. Emma, please, the floor is yours, but stick to the time if you can, because we have a lot of panelists. Thank you.
Thank you so much for that introduction. The slides, can the slides be shared as well? Thank you. So my name is Emma Nichols, and I'm going to talk briefly today about estimation of the global burden of dementia, some methods and results from the global burden of disease study. So I'm going to start with a brief primer about what the global burden of disease study is. It strives to be a systematic and scientific effort to quantify the comparative magnitude of health loss from major diseases, risks, and injuries by basic demographic factors and over time. Centers on the fundamental premise that policy should be informed by valid, reliable, and timely data. And the key principles of comprehensiveness, the idea that informed estimates are better than no estimates, and comparability. There have been recent increases in collaborative efforts with the WHO, which aim at boosting GBD efforts and uptake of results. So I'm going to start with a brief discussion of the case definition. In the GBD study, the gold standard case definitions for dementia are the DSM or ICD definitions from representative surveys. We see that there's some consistency in the definitions used across studies, but large variations in the methods used for the ascertainment of dementia. Out of the 287 sources cataloged on prevalence and incidence, we've documented 279 different diagnostic procedures, which really highlights the heterogeneity that we see and underscores the sort of lack of consensus on the best way to measure dementia across different contexts. So we know that in the past, we've seen an almost threefold variation in age standardized rates across countries, but it's unclear how much of this is due to true variation in prevalence estimates versus variation due to heterogeneity in ascertainment methods. And this problem is somewhat compounded by issues related to data sparsity. We have a decent number of prevalence and incidence sources, but these are geographically clustered in high-income areas, where we have more sparse data coverage in Latin America, Sub-Saharan Africa, Central and Eastern Europe, and Southeast Asia. And so we take these into account and have developed prevalence estimation methods to try to address some of these limitations in our data. First, we like to address data heterogeneity. And so we've grouped the previous heterogeneity and variation that I described into 6 main categories. 2 describing different definitions, so the National Institute on Aging Alzheimer's Association definition and the 1066 algorithm and methodology, as well as different methods of ascertainment and data type, including cutoff score algorithms, general practice records, clinical records more generally, and US claims data. And to adjust these data to our gold standard definition, we use a Bayesian network meta-analysis to estimate adjustment factors. Here, the unit of analysis is really the comparison between studies. And by using the network meta-analysis framework, we can leverage information not only from comparisons between our reference criteria and our alternative criteria, but in addition, between different alternative criteria. And therefore, we can leverage more information and gain more precise estimates. Once we have comparable data, we can then use this data in DISMOD MR 2.1, which is the age-integrating Bayesian meta-regression tool used widely across GBD. One of the primary features of this model is the geographical cascade. And this helps us solve the issue of data sparsity I referred to earlier. How this works is first estimates are done at the global level using all available data. And then within the Bayesian framework, these estimates are passed down as priors to the next level of the hierarchy, to the superregion level, and then to the region level, and then to the country level. And while this works in practice, is that where we have data in a given country, estimates are informed by that data. But where we don't have data, estimates are instead informed by the prior from one level above in the geographical cascade. And therefore, we can create estimates where we don't have primary data. And the second piece is the fact that it's a compartmental model, which aims to find consistency between the different parameters of incidence, prevalence, mortality due to dementia, and mortality due to other causes. And so here we can leverage data from these different parameters, in an example on the right, and showing how the model finds a consistent fit between these different pieces of information. And from here, we can generate maps that look like this, showing the prevalence by country of dementia among males, age standardized in 2019, and understand some of the variations in the distribution that we see across locations. We can also sort of zoom out and take a look at global trends, where here we see in red fairly stable rates of age standardized dementia over time, age standardized rates, which is contrasted with large increases in the global number of prevalent cases due to trends in population aging and growth. So now I'm going to take a few moments to talk about mortality estimation. In many other diseases across the Global Burden of Disease Project, we rely on vital registration data as a rich source of information on mortality due to a specific disease. But in dementia, we see clear biases and issues in this data. In the US and Argentina, we see large increases over time, which you can see on the slide, whereas it's fairly flat in South Africa. But if you look also at the y-axis, you can see large discrepancies in the level of mortality across these different locations. And importantly, we don't see similar trends, either over time or across locations, mirrored in our prevalence data. And because we know that there have been few differences or changes in treatment over time, we believe these differences must be due to differences in coding practices. So we need to come up with a different alternative way to estimate how many people die due to dementia as an underlying cause of death, sort of mirroring this underlying cause of death philosophy that that is used in vital registration data. And so to do this, we use two primary data inputs. The first are mortality risk data from cohort studies, from which we estimate the excess all-cause mortality due to dementia. Here are some of those results showing attributable risk increasing over age. The second piece are clinical death records linked to clinical data linked to death records, from which we estimate the proportion of dementia cases with markers of end-stage disease before death. These markers really indicate that an individual is towards the end of the progressive disease process and therefore is more likely to have died as a direct result of their dementia as an underlying cause. And an example of a couple of these conditions are pneumonia, dehydration, urinary tract infections, and decubitus ulcer. And we can combine these two pieces of data then to estimate excess deaths with markers of end-stage disease, which we call dementia deaths. And you can get a sense of the overall trends. On the left, we show stable trends over time, which is in comparison to the more volatile patterns we saw in our vital registration data, with increases in the number of deaths by age and more deaths seen in females as compared to males. And finally, I'd like to end with some big picture results and conclusions. One of the strengths of the GBD study is that because we estimate all causes of disease in a comparative fashion, we can actually look across different causes at measures and metrics of mortality and of morbidity and overall health loss. So on the left, you see years lived with disability and the ranks and how they change from 1990 to 2019 among adults 70 and older. You can see Alzheimer's disease and other dementias increasing from 10 to 7, and likewise in terms of overall health loss increasing from 6 to 4 globally. And you can also then get a better picture looking by age group at overall health loss, comparing dementia to other diseases within the category of neurological disorders. And you can see dementia constituting a large proportion of the burden, particularly at these oldest age groups. And then finally, I want to wrap up by just saying a quick word about COVID. We know that many deaths among older adults and among individuals with dementia have been due to COVID in the last 6 months. For us, importantly, we want to consider how these deaths among those with dementia are not actually due to their dementia as an underlying cause of death, and then potentially incorporate that into future estimates to understand whether or not this will affect the number of individuals who actually die from their dementia. And second, we want to consider some of the reports of brain fog and potential long-term neurological consequences of COVID. And future research should investigate whether or not this might be a risk factor for dementia or impact future prevalence. But obviously, we know that more time and research will be needed to understand how this will play out. So with that, I'll wrap up, say thanks for your attention, and I know there'll be a Q&A session later, and I'm happy to take any questions if people have them.
Thank you very much, Emma. Now, I'm going to stop us here for a second for two reasons. A, I've got the results of the poll. And secondly, I want to make a number of questions. I want to put a number of questions to Tarun and to Emma that then hopefully will inform the second part of this roundtable. Once again, this is a roundtable, it's interactive. So from the point of view of the poll said that 21% of people online right now are research or academic professionals, 12% others, we don't know, 50% are health professionals, 5% care professionals, 4% industry, 8% members of ADI organizations. So quite a lot of health professionals, quite a lot of academics. So thank you very much for being with us. When I last checked, there was over 250 people on the line. So the questions, there is a lot of information in the slides that we have seen, and bear in mind that they will be available on recording, so you can go back and see them with greater calm. But I would like to put a question to Tarun and one to Emma before we move forward. So Tarun, from your point of view, how will WHO use the new figures on prevalence to progress the Global Action Plan for Dementia, which ultimately is what you and I so much want to happen? How will WHO communicate also the new figure to the public? Because of course, so far it's been very much ADI providing the figures to the members or anyone that wanted to do advocacy. So how do we get the figures then once you start publishing them? Thank you.
So thanks, Paula, for this very important question. You mentioned in your introduction about the Global Dementia Action Plan, and the action plan has 7 strategic objectives, and all of these are interlinked. So the numbers, the burden numbers, and when I talk about burden, it means in terms of not only the prevalence, but also the cost. They guide us the policy response. So a country, what kind of a policy it should be developing, how it should be implementing it. What kind of awareness raising strategies they should be implementing in the communities. The most important implication, and some of this we are seeing in terms of COVID-19, is how do we organize our services? How do we organize our health and social care systems? How do we take into account the long-term care systems? And the numbers help us in doing that. We should not forget that for every person with dementia, there is we also have the caregivers. So this also helps in organizing services for caregivers. The numbers are important also for, when we think about these numbers, the most important thing that comes to our mind is, can dementia be prevented? How do we get into account, how do we put into place the policies for risk reduction? And something that, of course, it also drives the research and innovation. And so all of these information is extremely helpful at global level, at regional level, at national level, by a variety of stakeholders to organize their country responses. So they are an important piece of the puzzle. At a national level, you design your response.
Thank you very much, Tarun. That is extremely helpful, I'm sure, to a lot of people online that are wondering exactly that. Emma, from your point of view, can you tell me a little bit more how IHME is collecting data? What is your methodology? And what are the key points and trends that you are seeing in your newest finding? Anything new that you can share with us?
Yeah, I think, so to answer your first question, in terms of collecting data, IHME doesn't directly collect any primary data, but instead we rely on systematic reviews of the literature to make sure that we're up to date in all of the data that is publicly available. And we update these every couple of years just to make sure we stay abreast of anything new that's released. And then additionally, another key area is that we rely heavily on input and collaboration from our network of collaborators, which crosses almost every country around the world. And includes over 3,000 different collaborating individuals. Anyone can sign up. It's free and easy to do. And we ask that collaborators provide input into estimates and data sources. And so they're sort of a key way that we make sure that we're not missing anything that could potentially help inform and improve our estimates. In terms of key results, it's not necessarily something new. It's something we're all sort of aware of. But I think one of the biggest takeaways is this increase in numbers of individuals affected by dementia that we expect to see into the future due to trends in population aging and growth. And with that, in terms of looking at GBD estimates and the comparability across causes, understanding dementia as a leading cause of morbidity and mortality globally. And I think additionally, to complement sort of what we know about what we can see from our estimates, I think it's also key to highlight and point out some of the limitations of dementia estimation in terms of the data heterogeneity and data sparsity in many places, and sort of use this as a call to ask for and sort of put forward more of these data collection efforts, which we know are of vital importance and incredibly necessary to inform sort of what we know about the distribution of prevalence and improve estimates into the future.
Emma, thank you very much. Would you just say, in a way, sort of makes even more relevant the work that 1066 has done in the past, and hopefully will continue to do in the future as a primary resource source, data source. And as I said in my plenary this morning, when data was not there 10 years ago, we just went out, invented a methodology, thanks to Martin, and went out and found our own data. And it looks like we will continue to need to do that, really. So, Martin, Melaine, this is really your turn to tell us what's happening with 1066 and your view on what Tarun and Emma have just told us. Martin, I understand you go first and Melaine after.
That's right, yes, so I'll try and be brief so Mylene can comment. So with regard to what 1066 has been up to, the last 5 years, our colleagues, 1066 colleagues in Latin America and China have been working hard under quite difficult circumstances often to complete a new prevalence wave and also following up those people who originally participated in our research in the first decade of this century, roughly now 10 to 15 years ago. So the fieldwork has finished for those surveys, and we're hoping to complete and finalise the data sets so we can analyse those. I think one of the most interesting and important aspects of that bit of work is to compare those two snapshots in time with really at least a 10-year interval between them in order to understand, using the same methodology in the same catchment area districts, what actually have been the changes in prevalence of dementia and other important chronic non-communicable diseases in these older populations. And then what about help seeking? Are people more likely now to get a diagnosis of dementia than they were before? Are we seeing any increases in prescription of the acetylcholinesterase inhibitors, for example, that may be helpful with cognition? What about needs for care? Are those going up, coming down, staying about the same? And how are these being met? So has the gap in care provision to some extent been closed? What are the impacts on family caregivers? So aside from our own primary research, there's also a lot of continued interest in using 1066 methodology. A lot of effort was put into the development and cross-cultural validation of a wide range of tools for surveys. So I've recently heard that the national government-sponsored Older Persons WISE survey in Singapore is going to be repeated, which is very good news. And we've also had contacts from Lebanon and Nepal with interest in using our methodology in grant-funded studies. And of course, there's the STRIDE study, but we're going to hear about this shortly. So beyond that, I'd say that personally, my own focus as a researcher has more or less completely shifted towards intervention. What do we do about this? with a conviction that in low-resource countries, the fundamental problem is a health and social care system problem, that we're not really going to make progress unless we actually find a way of adapting systems so that they can just begin to respond to the healthcare needs of older adults in general, people with dementia, their caregivers in particular. So that's really what we're putting a lot of effort into at the moment, particularly around the WHO's Integrated Care for Older People, or ICOPE guidelines. I think we absolutely need to continue the work of searching, cataloguing and appraising global epidemiological research, scientific research into prevalence, dementia, incidence of dementia, associated mortality and costs. I think one of the issues with that is sustainability. But I think IHME, with their enormous networks, have been doing a fantastic job of putting together a mechanism whereby that might be taken forward. I think the approach that we developed for doing this in our initial work with ABI and WHO was very much, focused on quality epidemiological research that was actually producing something in a research context, an epidemiological survey that looked a little bit like a clinical dementia diagnosis. We put a lot of effort in critically appraising those literature to limit down the data that actually went into those estimates, 52 million, I think, in 2017, rising to over 150 million globally by 2050. In fact, the estimates that IHME are coming up with at the moment look very similar numerically, globally, to those ones that we developed earlier. So I think there's a need for continued scientific epidemiological research. I absolutely agree with Emma about that. But as far as monitoring is concerned, if I was, a Minister of Health or Social Care in a low-resource country somewhere around the world, I would think that what actually I need is government-sponsored repeated surveys, so that we need a module within demographic and health surveys that relates to older people and their health circumstances. It won't be dementia specific, but if it's got a bit of information about cognitive function, about disability and functioning, and about needs for care, as well as access to healthcare services, dementia is a global priority at the moment, and that needs to be reflected by that commitment by governments around the world to putting in that monitoring activity. So I think absolutely the stuff that we've been doing, that IHME are doing, pulling together all these diverse data resources are really important, but advocacy needs to be directed towards government to take on these tasks. And some of the tools that, for example, 1066 and STRIDE is working on now, I think are really, really relevant for that purpose. So that's all I've got to say at the moment. Thank you.
Martin, that was brilliant. Thank you. So we still need to do a lot of work. And actually, you talked of LMICs, but I remember this terrible report of ACD that said that in higher income countries still dementia was so not reported, and there was so much work to do. So we really have a massive work, which again stresses back the importance of the national work. We need to do the national work. We've got 132 nations in this conference today. So I hope everybody is listening to what we are saying. We do need the national work. Mélène, you have done a lot of work at granular national level. Briefly, let us know what you think about it. We could go on speaking about this all afternoon. This is a fascinating topic.
Yeah, I agree with you, Paola, and thank you for letting me share a bit today about this. I think we've talked, Emma's talked about it, and you all talked about it. Things have greatly changed over the last decade, probably, in terms of evidence we have, and it's changed a lot in low and middle income countries. I've seen it as well over the last year with my involvement with the Global Brain Health Institute. But I think what I can maybe highlight as well is the more and more interest I hear about around dementia in sub-Saharan Africa and other African countries. There is more data published, but there is definitely more data to come. And I think it is, to me, really positive, because that's definitely what's needed obviously to kind of complete the global numbers and make them more accurate, but also to push for policy and make a case for non-communicable diseases and older people in those countries.
Belen, thank you very much. People have been sending me messages saying you're looking at your phone. I am looking at the questions that are arriving to this panel, of which there is a lot, and they're quite complex. So I even had to put my glasses on because I have to read them in detail. I will try and pick a couple of them at the end. Some are quite complicated. So I need to decide how we're going to answer them. Whilst I do that, can I ask Adelina to please come on board? We've been doing a lot of work with LSE, with the STRIDE project, which has been mentioned many times today, the way that we are granularly reflecting on healthcare systems of countries in order to make intervention. Adelina, the floor is yours.
Thank you, and thank you very much for inviting me to take part. I mean, this is a great panel to be in because our project, it's very nice to see the genealogy of the projects, and ours is very much following on the footsteps of 1066 and very much also on what Martin mentioned about trying to understand the systems and how can we improve the care and how we can use all this data we are collecting to improve care. I'm going to talk about one aspect of STRIDE, which is how we're going about estimating the costs of dementia and how we're trying to do this in the most useful way as possible. And then Emiliano will discuss how we're going about adapting and learning from 1066 and measuring the prevalence of dementia as well. STRIDE is, if you haven't heard about it, if you've managed to avoid it this far in the conference, that will be quite surprising because we have a big presence here, but it's a project looking to strengthen responses to dementia in 7 middle-income countries in Brazil, India, Indonesia, Jamaica, Kenya, Mexico, and South Africa. And I am checking just in case I don't miss any voice, so I'm looking down. Our approach is very much that it's great to have a big figure on the costs of dementia, but what we want to know is how to use this information on costs to help us spend better and to help us understand who's bearing the costs of care and looking beyond the distinction just between health, long-term care, families. We also want to know which types of care settings and in which parts of the countries, for example, or which socioeconomic groups, which ethnic groups may be left behind when it comes to that. Now, the challenge is that we have little data, and in STRIDE we only had enough funding for field work on surveys in 2 of the countries. So we've come up with a methodology that is trying to make the most of everything we have, all the information and knowledge that we can find. And we're using a combination of systems analysis. We're looking at dementia care as a complex system, and we're using participatory methods, and as well as building on the expertise of teams and extended national advisory groups to develop a picture of what's available in the country, what people are using, and what are the care pathways of different groups of people. And we are doing a lot of work. We started using some case vignettes that have developed in the care pathways and using consultation with experts, NGOs, with everybody we can get hold of to try to get a sense of the diversity of pathways available to people. And then from that, we're taking a step back and we're looking at how we can quantify how many people are in the different groups with different experiences of care. And from that, we're building up a model. It's quite a different approach, and we are trying to, of course, use all the surveys and data that are there, even if sometimes they're not about dementia, they may have useful information about certain socioeconomic groups or age groups that can help us complete the picture. It's a bit of a large puzzle, but we do hope that by doing this detailed work, we're able to shed some light on the different experiences and the size of these different experiences in different countries and contexts around the world, and that this provides detailed information that help improve the access to care, treatment and support of people with dementia, and support for carers in these very different contexts. Thank you.
Thank you very much, Adelina. Now, we have had a number of questions, some of which can be subsumed in some of the thinking that we had preparing this session. So I have a question for Martin and Melaine, which is, in your view, how do you see a way to harmonize then the work of 1066 with the work of IHME? And this is also coming from a couple of members of the public and from a couple of messages I have received personally. What's your view? Melaine, would you like to start first, as one of the people was particularly referring to Africa?
That's a good question. I think the 1066 work and original data collection, as was saying Emma, is actually feeding the work of IHME. So I see them complementary. Obviously, the diagnostic criteria is something that might need some adjustment, as she said. But yeah, I think I see them complementary more than anything. I don't know what Martin thinks.
Martin, your turn. Give us a global view, because you've been talking very briefly.
It's not really merging the work of 1066. I think it's merging the work that some of us at King's were doing with ADI and WHO with the IHME approach. And I think fundamentally this is all about kind of data sparsity and how to deal with it. And there are actually a lot of similarities between what we did and what IHME have been doing. Although their approach is a lot more sophisticated, but the kind of hierarchical approach we modeled within regions, and then we, where data was missing, applied the regional model figure to all of the missing countries, whereas they go right down and model to individual country levels. So my slight concern about that is where data is so sparse that there isn't any, is that it can produce some quite outlier estimates, which is a well-recognized issue with modeling. So, you know, the global numbers and the regional numbers work fine and work equivalently well across the two levels. But I think, you know, your clients, ADI, your country members who want to know, you know, how many people with dementia are there in our country where no research has been done, I think that's the level where we need to be a little bit careful and perhaps do a little bit more fine-grained work.
Thank you so much, Martin. Which brings us to Adelina. Adelina, how do you think STRIDE is helping with particular granular work? There is also a very interesting question here around multimorbidity, and I know that that is one of the problems we're facing. I remember one of the reports that came out a couple of years ago was pointing out that because people have got comorbidity, then dementia often is left out. What's your experience with STRIDE? Briefly though, because we still have Emiliano and Anders to speak. Thank you.
No, we're very much in the business. We're very much in the business of filling in the gaps where we have very little data. As I explained before, we're trying to understand different care pathways, different ways of accessing services people have, and that will, of course, then tell us about their experience and cost. And when it comes to multimorbidity, we know quite often that what we'll observe when we try to estimate costs will be a combination of costs that are due to dementia and costs that are due to their other conditions. But of course, for people with dementia, the need of services that are targeted and adapted to their, for example, if you think of a hospital admission for a person with dementia, it's quite different than for a person who doesn't. I think what we want to know is what's the health and care system experience of people with dementia, and then use this information on cost, service use to be able to plan better the services available.
Thank you so much. I will now move to Emiliano. Emiliano, give me your perspective, especially around the issue of harmonization of data. How do you think we can link the work of 1066 to other interventions? There are quite a few. How can we develop a toolkit?
Yes, exactly. So I think that we have to recognize that one size does not fit all for a number of reasons. So I think that I want to remember to everybody that the WHO Global Action Plan on a Public Health Response to Dementia is a major achievement, fantastic, and a great opportunity as we stand. And I would like to remind to everybody that Alzheimer's Disease International has been crucial in attaining this goal because of the public engagement and giving voices that are often silenced of people with dementia and their families. It's not just giving numbers, but of course in funding and supporting largely dementia research through the 1066 group, which is particularly concerned with low-income countries where the evidence was sparse, if not inexistent. So where are we now? Well, as we heard from Tarun as well, the Global Dementia Observatory is a framework which is dotted with indicators across the 7 action areas. And some of these deserve our attention today because they concern particularly aspects of how we respond to the needs of people with dementia and their families. And I'm talking about the diagnostic, treatment, and healthcare gaps. Well, these 3 gaps, which are estimated to be really, really big and wide, can be measured. And how will we make in closing these gaps? Only if we conduct epidemiological research. And as Marty was saying, we need this at a country level because we need to understand not just how much and how big these gaps are, but why they persist over time so that we can address them in a best way. Now, just to give you an answer about what STRIDE has attempted to be doing, building on the experience of 1066 in countries that are middle income, so where some resources have been put also in changing the health system. Well, we reviewed the evidence of prevalence in these sites, and not just to have the numbers, but also to run critical appraisal of the methods that have been used so that we could give answers to how do we measure dementia staging, the severity of the disease, not just cognitive measures, but social demographic costings that would be here, and other aspects like the neuropsychological symptoms, depression, and many others, like the quality of life and well-being and disease-specific quality of life measures, care burden, stigma, and health reviews, all of which are part of the equation when we want to give a response of the burden that dementia imposes on those who are affected, but also on society at large. So the toolkit. Well, the toolkit is the next step to scale up the 1066 in a way that this is essentially what ADI may give to the World Health Organization as a resource to member states or all those parties who are willing to conduct nation-level surveys. The toolkit will enable standardization, of course, but will come not only with what you need to conduct the research, but also the infrastructures, the procedures, what we call the SOPs, so the standardized operation procedures, so that countries are assisted all through the process of conducting these surveys that may be time-consuming. And Martin mentioned that. We need a political commitment. We need countries to understand that the survey is not just one shot, and it's not just the academic and scientific world that should be concerned. And actually, there are already fantastic examples of this that has happened in the Caribbean, for instance, with a study that was actually embedded into a national survey in the elderly that was essentially using part of the 1066 diagnostic algorithm. And that worked in a fantastic way. And in conclusion, it demonstrated that the estimates of prevalence in that very country were much lower when they were calculated based on approximations than what the reality was of the country itself. And this, I think, is a jolly good example to remind to us that we need country level estimates, we need the political support, and we can hand over to the WHO a toolkit through Alzheimer's International to let all member states be able to do that in the coming years.
Thank you very much, Emiliano. I can feel the amount of work piling on our shoulders, but then that's what we do. Thank you so much. I have another question for you, but before doing that, I would like to give the floor to Anders. And then I have a number of really poignant questions that are coming in. I'd like to pick up at least a couple before we finish. So Anders, I give you 5 minutes, but you would need 5 hours to tell us what you're doing. But 5 minutes will have to be 8. Thank you.
Thank you. Or 5 days, perhaps. Well, I have the privilege to have a very close collaboration to all the big players now in global dementia issues, by WHO, by IHME, and by ADI, and also by STRIDE in a way. And that's crucial for me since I'm collecting data about cost and resource use from all over the world. Currently, I'm working now on an update on the global cost estimates for the GDO in WHO. I think we have these figures finalized in a couple of months, hopefully. But I think many people think that in cost effectiveness studies, it's the dollars that are of interest, you know, $1 trillion and $2 trillion, whatever it might be in a way. But that's not the major interest for me, as I can see it. It is more like how are costs or resources distributed in different parts of the world, in different regions and different countries and so on. Another thing, of course, how are costs distributed between different payers? How much is due in the medical sector? How much or which proportions do we see in the social care sector, including long-term care and home services and so on? And also, of course, what's the contribution or proportion of unpaid work by informal carers in a way? And perhaps also, and what's happening over time? What are the time trends on these issues in a way? And another important issue is, of course, what the gender aspects. We know that female are the major informal care providers, also informal care providers in a way, and how is it changing over time in the world, and also what's the impact on the labor market and so on? What are the consequences to be an informal carer when females entering the working force, which you should do, of course, in a way? And what's the level of long-term care infrastructure in different parts of the world, and what's happening over time? I think that's more of interest than the single dollar figures in a way to look in a way. But of course, we have very, very great challenges in this area. And the greatest challenge is, of course, first, the missing data, as mentioned before, because we don't have so much cost data from lower middle-income countries in the world also. And also, of course, the under-detection of dementia diagnosis in a way, which is also apparent not only in low middle-income countries, but also in high-income countries in a way. So I think we're facing very great methodology challenges here in a way. And for that reason, I see, and we need a very close collaboration between all these important players in the global dementia field to have access to different sources to make these estimates or resource using costs.
Well, gosh, I mean, yes, thank you very much, Anders, and thank you also for adding a few elements that we haven't talked about yet, like gender, that we know are absolutely essential, and there's going to be some panels at this conference talking specifically about that, and that clearly, as we have said in the past, is one of the big issues. Now, I have a question for you both. I'd like to give the panelists a challenge. If any of you has a question for another panelist, can you briefly think about it and then put your hand up whilst I ask this question a second to Tarun, that quite a lot of people are putting forward. So I give you a couple of minutes to think about what possible questions. If you don't have any, no problem, because we got more questions coming in. Tarun, the question that a lot of people are asking is, when will data be available? So if you got an approximate a date of when the data will be available, and how will it be possible for people to extract the data?
So, as I mentioned, Paula, in my slide, that we are planning to launch the global status report in the first part of 2021. The launch was delayed because, understandably, due to COVID-19, the prioritization has been on to the COVID-19 response. What we are seeing as we are looking at the data, that there is quite a bit of acceleration that is required. We need to do much more than it is currently happening. And I think what we want to give this as a challenge to all the stakeholders, and we wanted that this data gets appropriate attention. So the idea is that, again, it will be right now the situation will depend upon how are things with COVID-19, and fortunately with the vaccination coming in. We will have a better understanding, but our idea is that in first part of 2021, we release this data and then disseminate it widely. We would like to partner with and work closely with all of you who are around, including ADI, which is our important partner in crime, in doing all the work that is required around dementia. The second point that I wanted to make, and Emiliano had touched upon this, that one is, of course, these numbers that we talk about, but the importance is also that how are we improving our data collection systems in the health information systems. And that is where much more work is required. So population-based surveys and the research data is one thing, but unless and until health systems are strengthened to collect better data on dementia, we will not be able to move forward. And the other point that I wanted to emphasize, and which is also part of our GDO, that in addition to diagnosis rates, we need to look at the care facilities, the access to services, the provision of those services, because that is the most important part. Ultimately, it's not about that how many people are there with dementia. It is about what kind of services are being available to them and their families. And STRIDE is trying to address that. Many partners are trying to address that. I see ADI national associations trying to address that. So I'm hoping, by the time we are in 2025, we are able to have a better system of monitoring through the health systems. And this is where we would like the much of investment to go in future. So, Paula, again, like Anders, I can go and on. We are very. This is an issue that is very important to our heart.
Thank you, Tarun. But this is a key issue. As I said at the beginning in my first presentation, unless we start inserting dementia in that thinking everywhere we go, and we can only do that by all of us working together, as you suggest, and make sure that governments keep it in mind that they have to provide that data. They have to make it part of their thinking, and we are not there yet. So I can imagine another 2-3 years of good, solid work before we get there. Now, very briefly, we've got very little time, but Adelina has told me that she's got a big issue on her mind that she should have mentioned. So Adelina, I give you the floor for 30 seconds for the big issue.
Thank you. So the issue is, how can we use all this data to improve the services and the experience of people? And here is where I think it's very important that we move with our conversation and how we present our results. And I think we've talked a lot about costs. We've said a lot that dementia costs a lot. But what we want to actually say, I think, is that we're not spending enough in dementia care treatment and support for people to have good lives. And I think it's very important that we flip our narrative and we talk about the resources that we need to improve what we are delivering. STRIDE is very much trying to do that. We're doing a cost of dementia just as a baseline, but what we want to project in the future is not how much we'll spend if we continue doing what we're doing today, because we know that what we're doing today is too little. We want to show how much we need to put in if we want to achieve the improvements and in the outcomes and the experiences of people that the stakeholders, including the governments, would like to see. And that's my plea for the future, that we change the narrative and we think more about how can we spend better, how we can attract more resources to this sector rather than complaining that it costs a lot. Thank you.
Thank you very much. It was an important point. Now, I really apologize, but we unfortunately have got less than a minute left. So I'd just like to summarize why we did this panel. We have had over 350 people listening to us at some point. So really there is a lot of interest for what we are talking about. Now, to all of you, we've done this because it's a very important thing that the WHO is subsuming the data on dementia in their own global reports on the burden. And this is a massive step forward for all of us. Remember 10 years ago, nobody really knew numbers. Now they're going to be official. This is fabulous. But we must not put the foot off the accelerator. This is still everybody's interest and everybody's task to work together to make sure that the data still comes in and that the data is verified and real. So it's still very much the task of our grassroots movement. Thank you so much to all, and over to direction for the next section. Thank you, my panelists. You've been great.
Thank you.